We're going to talk about extraction of a maxillary first molar and socket preservation with bone graft and platelet-rich fibrin. You can see this maxillary first molar has had endodontics and apicoectomies with retrofill, so that tooth has been rode hard and put up wet. It has had everything we know to do to preserve a tooth short of extraction. And now we can see the infection, and there's a fistula on this mesial root. Because the sinus floor is right here, we only had about 5 millimeters of vertical bone from the alveolar crest to the floor of the sinus. You can do a sinus lift with bone graft and implant, but this patient had a good tooth distal to the extracted tooth and a good tooth mesial to the extracted tooth, so it was decided we would place a bridge. So we're first going to draw 4 vials of the patient's blood and spin this down, and it will form the platelet-rich fibrin. Now you'll remember platelet-rich fibrin is rich in growth factor, and it enhances healing. We're going to spin this down. Now we always spin 2 cycles. We found that most of the time 1 cycle does not create the platelet-rich fibrin clot. So you can see this yellow clot in the top part of the vial, and that's the platelet-rich fibrin. And see how it comes out like a clot. And you're going to cut this off to leave the blood part in the vial, and you remove the platelet-rich fibrin clot. And you put it on the tray, and we're going to put a top on this in just a minute, and that'll flatten it out. So I've removed the crown from the tooth to be removed and sectioned. This is a small, very coarse diamond burr. And I'm going to cut this molar into 3 parts where the 3 roots are. So we know we've got a palatal root and 2 buccal roots. So I'm going to make a cut mesial to distal, and I'm going to make another cut through the 2 buccal roots, palatal to facial. It's very important that you cut all the way through the tooth to the alveolar process. You can see now they're deep cuts all the way into the alveolar process, all the way through here. Then very gently with an elevator, I'm going to separate these pieces. Now when you place the elevator, be sure you place the elevator deep into the tooth, especially on the buccal roots. If you place the elevator just right here, very shallow into that cut, you'll fracture off the coronal part of those, the buccal parts of the root. You always remove the buccal roots first. So you got them moving, and then just twist them out, kind of unscrew them. The reason we're doing this, why do we not just take them out take the whole tooth out to the buccal in one fell swoop? Well, you lose the buccal plate. We want to preserve the socket, so when we place a bridge, it's not like a sway-backed horse. We've got a nice ridge. It creates a better gingival ponic receptor site. So I'm getting all the pieces out and then curetting really well. Get all the granulation tissue out of the socket. Everything is spotlessly clean. You can see the floor of the socket, all bone, and all the granulation tissue is curetted out. Now I'm just scrubbing it clean. This is a cotton ball held by cotton forceps with Paragard, chlorhexidine. Okay, I'm releasing this tissue on the palatal just a bit, because when I place my platelet-rich fibrin membrane and my resorbable collagen membrane, I want to tuck that in to under the palatal gingiva and under the facial gingiva. Now these platelet-rich fibrin clots have flattened out. I'm going to take a couple of them and cut them up and mix them with my cancellous bone. Just cut them into little pieces. And this is Biwas cancellous freeze-dried bone. I'm going to mix this together, and then I'm going to draw the serum from the flattened platelet-rich fibrin clots, which ends up in this little cup in the tray. And I'm going to draw that up, and I'm going to use that to wet the freeze-dried bone. Mix all the platelet-rich fibrin with the freeze-dried bone and pack that into the socket. Now you don't have to have primary closure of the gingival flaps. And the reason is, if I wanted primary closure, I would have to reflect all the way down to the non-keratinized gingiva and probably make releasing incisions here. I'd rather keep that gingival flap connected to the bone, to the alveolar process, so we don't lose blood supply. So this is Dynamatrix resorbable collagen membrane, and that membrane will stay in place and not dissolve for about 3 months. The purpose of a membrane is to give the bone a big head start on the soft tissue. Soft tissue heals faster than bone, and so if you don't place a membrane, the soft tissue will grow into the socket. So these are tucked under here, so the soft tissue can't get to the bone graft for about 3 months. Then I'm going to place my PRF, one of those membranes, on top of the resorbable collagen membrane. So we've got cancellous freeze-dried bone mixed with PRF, then we've got a resorbable collagen membrane, and now we've got a PRF membrane on top of that. Then we're going to suture. This is 3-0 gut suture, and we'll put 3 or 4 or 5 sutures across the PRF membrane just to secure it in place. And if you can, make your cuts on facial side so the patient doesn't feel it with their tongue. Tie the suture on the facial side, not the palatal side. You can see this is across here, across here, across here, there, and there. That's the dental minute.